my mentor, Dr. Jules Hardy from medical school. But let's talk about giant pituitary tumors. So the description was first coined in 1940s, but we'll define them as tumors larger than 4 centimeters in diameter. And they're common, pituitary tumors are common in the general population, but giant pituitary tumors are quite rare. The problem that you have is the following, is that they're large, they grow up, and they encompass the optic nerves, obviously, and the anterior cerebral arteries. And the presentation is usually visual problems and endocrine dysfunction. So we treat all prolactin-producing tumors with dopamine agonist therapy as first-line treatment, unless they don't respond or they can't tolerate the medicine. So how do we remove these big tumors? Well, this is a slide from Atul Goel, a good friend of mine from Mumbai, and it's a delivery, it's a finesse delivery. And we can get most of these big tumors down because we're lucky they're soft in most cases, and you can achieve resections such as this and maintain the pituitary axis. And it's amazing to me how you can have a large tumor like this and you can remove it and you have a wisp of pituitary gland, but you still have relatively normal function in many patients. You may lose the menstrual periods or the testosterone may be low in men, but often the thyroid and the cortisol are normal. So what are the tricks that I use to try and get the tumor to drop? Because that's the big key if you're going to come from below. This was originally Hardy's drawing, but I opened the dura in an X-shaped fashion, not in a cross, or I remove the dura completely. And the idea is the way you get a roof to drop is you take out the floor and the walls, and the roof will drop. And so then we'll use different tricks to try and get the tumor to come down. But what I like to do is not breach the arachnoid early on. I like to keep the arachnoid intact for as long as possible because this will help push the tumor down. And so we'll remove the floor of the tumor, and then I concentrate on the walls and the back wall. And I try to get the arachnoid and the diaphragm celli to come folding down, and I try to leave the CSF pressure behind it to use to help push the tumor down. Now we use Valsalvas during surgery. You can use bilateral jugular venous occlusion. Ed Laws taught me this. This is a big gun. You just reach under the drape. You can have the anesthesiologist do that, or you can do it through the drape itself, and you can actually get a lot of pressure to help push the tumor down. So when do we come from below and when do we come from above? Well, we've done transfemoidal approaches for most of them, and I'll show you my data. The advantage is it helps. It's easy to do the tumor from below, obviously. It's a very familiar approach for us. The problem is you may not get these multilobulated tumors to drop or the very tall ones to drop. So you can do a combined approach, and we've done that, where we do approach from above and below at the same time, and I think it's a reasonable option. The only thing that I'm concerned about is whether I'm going to infect the transcranial approach by having a dirty approach in combination with a clean approach. But we have done that on a number of occasions. If you look at the problems with these big tumors, the extent of resection is low, and the reason is because there's often cavernous sinus involved, and the mortality is high, and I'm going to spend a lot of time talking about trying to reduce the mortality in these tumors. But the mortality can still be very high, and even in the most recent large series, it's 4.4%. So they achieved 90% tumor excision in 74% of the patients, but the problem, as I mentioned, is that the tumor invades the cavernous sinus and may not be completely removable. So if you add the endoscope, it's helpful. And if you look at the literature on using the endoscope, and we use the endoscope routinely, no matter how you approach the tumor, the endoscope helps because it puts your eye where you're operating and you can look around corners and facilitate the tumor to enhance removal. So we looked at our most recent 100 patients that were done in the endoscopic area, and we're just publishing this now. But I want to show you some of the things that we've learned. So we looked at, out of 741 patients, we had 100 giant tumors that were greater than 4 centimeters. And this is the demographics of the patient, standard sort of age and gender classification that you'd see in pituitary tumors. The NOSP grade, though, was high in most of the patients. You can see grade 3 or 4. And just to remind everybody what the NOSP grade means, is it's progressive invasion of the cavernous sinus. So by the time you get a 3 or 4 tumor, you know that there's true cavernous sinus invasion, and the tumor will not likely be removed unless you knock out the oculomotor nerves. So these are the approaches that we used. In most cases, we used transsphenoidal, and we added transcranial in several cases. And these are the complications that we had. We had one ICA injury that was okay, CSF leak in 3 patients, and SIADH and meningitis. You can see that here. The outcomes, we had surgical control in 68 of the patients, re-resection and radiation in 35%, and the follow-up, you can see the range here in months, but the mean was 95 months, so we had good follow-up. But let me show you my philosophy with a few illustrative cases. So this is something to remember, that these tumors can undergo apoplexy. And this is a patient who presented with apoplexy. It's a giant tumor. And you can see that on the contrast image, there's no enhancement of the tumor. And we wondered what this was, and I wondered whether it was a cystic tumor, but he developed acute diplopia, bilateral 6-nerve palsies, and we operated on it, and the entire tumor was necrosis. So it's important to remember that the apoplexy can be necrosis, and it can be bleeding, and it can be a mixture and a spectrum between complete necrosis and just bleeding, okay? So necrosis can cause apoplexy. You see thickening of the mucosa of the sphenoid sinus around the tumor. That's a great indication of apoplexy, and we've published a series on that. And 6 months post-operatively, he's doing fine, and his cranial nerve palsies, his 6 nerve palsies improved in a few weeks. So when is a craniotomy necessary? The classic indications are the constriction of the diaphragm celli, or if you see these multilobulated tumors where you know that one lobule won't fall down into the cella. Paracellular extension, lateral extension. Sinus infection is a lesser one in my mind, because we often will go through the sinus even if there's evidence of previous infection. And then this last one, I'll go and I'll show you a case regarding that. But sometimes the carotids can be very close, as you know, these kissing carotids, we call them, and it gives you a reduced window. So if you think you don't have a large enough window to get the tumor to drop, then we'll come in from above. So let me show you some cases to consider. So what would you do with this patient? 57 years old. She comes in with cognitive decline, hydrocephalus. Look at the cell is very large here. So our residents put an ventricular drain in, and we got an MRI. And you can see a very tall tumor. Now, what I did in this, and I would do this different nowadays, but this is about probably 20 years ago I did this case, is I came in from below. This was a non-functional tumor, prolactin was normal. And I tried to do everything to get the tumor to drop from below. And I couldn't get the upper part to come down. And you can see what we've achieved here is we removed most of the tumor, but we still left the upper part. And so we came in the next day, and I came in transcranially and transcortically and removed the rest of the tumor. Let me show you this one. This is a case to warn you about. So here's a 42-year-old man, cognitive decline and headache. I operated from below on this patient. You can see the large tumor extending up to the lateral ventricles. And here's the CT scan. And I did a transnasal operation on him, and the tumor was soft, but I couldn't get it to drop. And so my plan was to bring him back the next day and take out the rest from a transcranial approach. And he deteriorated in the middle of the night. And I had to come in and do a quick transcranial approach to remove it. So this is a feared complication. You can see what's happened here is the tumor has bled. The residual tumor has bled. This is apoplexy in a partially removed adenoma. An incidence range from 5.4 to 12%, and it can be lethal. So it's an important rule that I use now is I use an approach as my first approach to control the mass of the tumor and trying to get as much of it out as possible. So let me show you a case I did more recently. This was 8 years ago with a tumor that I didn't think that I could get out from below because of this superior lobule. And so we'll come in transcranially and come in through the tumor and come down the long axis of the tumor. So here's his post-op scan. And I just show this to you because the cellar part of the tumor is not a problem, because if you follow the axis of the tumor down, it puts you down into the cella, and you can preserve the pituitary if you need to here, and yet we can get the tumor out without a problem. So we follow the long axis of the tumor right down to the cella. So the exposure of the cella by the transcranial route through the tumor. The other point that I would like to make is that these large tumors, they can wrap around the arteries, obviously, the anterior cerebrals, and you've got to be very careful. So here's an interesting case. Here's a gentleman with a large tumor, and you can see even on opening, he's had previous apoplexy. All the fissure is full of blood from previous hemorrhage by the tumor. And so when we remove the tumor, coming transcranially gives you much better control of the arteries. And so here I'm separating it from the bifurcation, and you'll see the optic nerves as well. And it's important that when you remove these tumors, you try to identify, there's the anterior cerebral that we're dissecting out, you try to identify the normal pituitary gland. And at the end of this video, I'm going to show the residual pituitary gland. So we've removed most of the tumor, and what you're going to do is you're going to feel for a firm structure. And what you see here is I'm removing the last of the tumor between the optic nerves that's attached to the pituitary. So there's the pituitary I'm pushing forward, and then we'll remove the tumor off of the pituitary and leave the residual pituitary gland if we can. And here you see, here's the residual pituitary gland. It's very firm. So you have to use the consistency to determine when you're on the pituitary. So this is another case I want you to think about. Here's a 62-year-old woman who 30 years ago had an operation for a non-functional pituitary tumor. And now she's got a recurrence in her cavernous sinus. Now she's got a 6th nerve palsy now, okay? So the 6th nerve palsy gives you more of an aggressive stance to go after the tumor, in my mind, because she's already got double vision. So we'll do a transcavernous approach. Now you say, well, we could do a transcavernous approach coming from below, and you certainly could. You can come lateral to the carotid artery transnasally and do that. But I chose to come in transcranially, and I'll show you why. So here's a Dolenk approach, Hakuba, Dolenk, peeling the lateral wall of the cavernous sinus, just as we learned many years ago from those two masters. And here's the 5th nerve, okay, foramen spinosum, which I'll divide the middle meningeal, we'll lift the dura up, and we'll identify where the tumor is accessible in the cavernous sinus. So this is between V2, or between V1 and the 4th nerve, so Parkinson's triangle. Now, when you remove the tumor in the cavernous sinus, you know that the 3rd, the 4th, and the 5th nerve are pushed laterally by the tumor. What you don't know is where the 6th nerve is. So now I'm looking for the 6th nerve. So you'll see I find it here, and it's discontinuous. And you'll see after I remove the tumor, I'm staring at the end of the 6th nerve. So it was running directly through the middle of the tumor. But if you come transcranially, you can pick up the 6th nerve at Dorello's canal, which is back here. So we'll remove the tumor in the posterior cavernous sinus, And there's the sixth nerve coming out of Dorello's canal. And you can freshen up the ends. And I had room here that we could just do an end-to-end anastomosis between the divided sixth nerve. Now, I always try to repair the sixth and the fourth nerves if we find this situation, whether you're in a meningioma or pituitary tumor. And the reason is these nerves only control one muscle, so they recover very well. The third nerve is terrible when you try to repair it. The outcome is terrible, but the fourth and the sixth do very well. So we'll fill up the cavernous sinus with fat, and then you'll see the post-op scan here showing just fat in the region of the cavernous sinus, but the tumor's done well. And she's done well, and she got improvement of her sixth nerve palsy over the next 6 months or so. And I'll finally show you this case. This is a case that was done in India, and Dr. Dia Bajari and I did this at Bombay Hospital. This is a 36-year-old man who had a recurrence of a tumor that was operated on twice, and they tried once from below and once from above. It was a very tall tumor. You can see it there. And it was said to be firm, and they couldn't get it out from either a frontotemporal terional approach or a transnasal approach. So what we did is we came in transcallosally. Okay, so this is an opening in the transcallosum. Again, the whole idea is coming down the long axis of the tumor. So we're going to just debulk the center of the tumor. It's like doing an acoustic tumor, and we'll then dissect the tumor from the surrounding brain around it, okay? And then you end up here in the cella. So we're looking inside the cella now. Now the tumor goes into the cavernous sinus on the left side, and you'll see we'll stop, and we won't go into the cavernous sinus. We'll just leave the cavernous sinus component alone. I'm reaching into the cavernous sinus there. So we were able to come down the axis of the tumor. Now we close, and what I always do when I do a ventricular approach like that is I plug it with some gel foam and some fibrin glue so we don't get hygromas. And here's the post-op scan. You can see the tumor's been removed, but we left the component within the cavernous sinus, and he had radiosurgery for that later on. So there's a few other tips that I just wanted to say in closing, that this is something that Ann Osborne taught me, is that these giant adenomas often have cysts around them. And these cysts can help with the dissection of the tumor if you do a transcranial approach. It often allows you to come around the tumor completely and separate it from the surrounding brain. And you can see these various cysts. And this is trapped arachnoid, we think, that helps with this. And then this is an important point, and something that I learned over the years, is that recognizing what you're going to be able to see through a transnasal operation. Now, it's important to remember that the third nerve runs from the interpeduncular cistern into an oculomotor cistern before it enters the cavernous sinus. And you can see the third nerve running through the oculomotor foramen. On this side, you can see there's tumor obliterating it. And you can see this is a path that the tumor comes through the third oculomotor foramen and then ends up in the subarachnoid space like this. Okay? So, and you can look at the T2 images and look at this, and you see the third nerve here on the normal side, but on the other side, there's tumor surrounding the third nerve in the oculomotor foramen. So what's the importance of this? Is if you do a transnasal operation, you'll never see this piece of tumor unless you open up the diaphragm celli, because it's going to be completely in a different compartment. Here's a cartoon demonstrating this. So you normally have the pituitary tumor growing from the cella and then elevating the diaphragm or growing through the diaphragm. And then if the tumor invades the cavernous sinus, it can go along the third nerve and end up in the subarachnoid space. But if you do a transnasal operation, you'll never see that, okay? So here's a case in point. So I told this gentleman here that I thought this was probably coming out of the roof of the cavernous sinus through the third nerve foramen. And I said I would remove the tumor, And we would watch this and just follow this. And the night after surgery, he developed apoplexy in the remaining component. But you can see we removed all the tumor, left the tumor in the cavernous sinus, and he had apoplexy in that segment. So I had to come in transcranial. So just a tip, it helps counsel your patients. And then finally, you can use the same techniques that we use to get the tumor to drop. You can use the same techniques to get tumor out of the cavernous sinus. And what I'm going to show you is this case here, which is obvious cavernous invasion, and it's into the middle fossa. Now, the lateral wall of the cavernous sinus is still intact. And so what you can do in that case, if the tumor's soft, is after you remove this portion, you can try to get this piece to come out with Valsalva or jugular venous compression. And so this is this paper, we call this the toothpaste extrusion technique. It's like squeezing toothpaste out of a tube. And once you get in there, you come underneath the carotid or in the carotid loop, and you find your windows to try and receive the tumor. So what we'll do is we'll get the endoscope, we'll have all the tumor cleaned out, and then ask the anesthesiologist to give a Valsalva or jugular venous compression, and then we'll remove the tumor as it comes out. So it's indirect removal. And you can see this case, we remove most of the tumor from the temporal fossa this way, just by giving Valsalva. So it's a way of reducing the residual. So indirect removal. So I think the last point that I'd like to leave you with is it's controversy what we do with these residuals. So here's bilateral cavernous sinus invasion. We remove the tumor, we decompress the optic nerves. What do we do with the rest of this? Do we operate? Do we radiate? Do we watch? I think that remains to be determined what the best treatment is. So in conclusion, these tumors are still a treacherous problem. Mortality is improved. It's 1% in our own series. Complete resection is not possible in most cases because of cavernous invasion. And I think the important thing for the young people is control the mass. Pick an approach that's going to get most of the tumor out. And then multimodal treatment with radiation is necessary in most cases. And I thank you very much. It's an honor.
Thank you so much, Bill, for this amazing talk and really a challenging surgery for these giant tumors. We thought at the beginning that we have more giant tumors in Morocco, in Africa, than you say, but you
that there is many giant tumors in
say also.
Yeah.
Fed.
Yes, thank you. Thank you, Professor Caldwell, for this outstanding talk, like every time, and thank you, Dr. Tawfiq, for introducing Professor Caldwell. Now if you the discussion, all questions are welcome during the discussion session by the end of the three talks, and I invite Professor Reguna Kandasamy from Malaysia, my dear friend from Malaysia. He is consultant neurosurgeon and lecturer, and the honorary secretary of the Neurosurgical Association of Malaysia. Please, Dr. Reguna, will you introduce our guest, Professor Luis Borba? Thank you.
Thank you. Greetings, everyone from Malaysia. First, I'd like to say thank you to and congrats to Dr. Derkawi and Professor Al-Abadi for a wonderful job that you're doing on this webinars. We've heard one master at work, and it was fantastic. Now, it gives me great honor to introduce our next speaker. He's an icon of skull-based surgery and vascular surgery from South America. Professor Luis Borba is the professor and chairman of the Department of Neurosurgery in the Federal University of Paraná in Curitiba, Brazil. Also, he's also an honorary professor in the Sessionov Medical School of Moscow and holds the presidency of the Brazilian Neurosurgical Society as well as the president of the World Skull-Base Society meeting. Now, his list of accolades and publications go on, and I've personally had a good encounter with him a couple of years ago in a skull-base meeting in Bangkok, where he frowned at when my presentation started touching on the role of gamma knife surgery for some distinct skull-base lesions. Now, you know, I was first taken aback, but I realized this sort of the reaction that I elicited was from the sheer passion that he has for skull-base work. Now, without further ado, the floor is over to you, Professor Baba.
Okay.
It's almost okay. Thank you. Hey, good night. Thank you, all the Moroccan people. Thank you, Professor Najla. I see Professor Al-Kabishi here, and our great master, Professor Caldwell. It's very difficult to follow him. Very nice presentation. And you see that now in America, they have big tumors also. So not only in our countries, you see, in South America and in Africa. I'll share my screen too. Oh, what's going on here? Was here, disappeared. Oh my God. 1 second, please. Let me stop sharing 1 second here. I don't know what's going on here.
Take your time.
I was just working on it, maybe here. Has to be here. This is the problem of technology, you know. I was just look at that and disappear. May I have to turn off here? Oh, keynote's not to answer. Try again.
Luis, maybe you need some help from
No.
Fed.
Can you go ahead before I was just working in the keynote here. Can you talk before? Can you give a lecture before?
Yes. Yeah, of course. If you
No, I was here. I don't know.
Please.
I have to turn off my computer here. 1 second.
Okay.
So, Professor Baba, you prefer us to go to another to the third talk?
Yes.
Come back. Okay. So I will ask Professor Shlawi. Professor Shlawi, are you here?
Yes. Do you hear me?
Oh yeah, yes. I have here.
Professor Shlawi is. You have the talk.
Yes.
So we go.
Yes.
We go with the talk. Okay. Yeah.
Let me see if I can share. Okay. Sorry.
You're welcome. No problem. It's technology.
Yes. Okay. Can you listen? Can you hear me? Yeah.
Yes.
Okay.
Yes. Okay, Luis.
Good. Thank you.
Okay.
Sorry for the
No.
computer getting wrong.
Don't worry.
Do you know, craniopharyngioma is a complex lesion. Craniopharyngioma is not so easy that the people say. Professor Yashagil, I will say that maybe the most beautiful surgery and the worst post-op you can get. The video can be very nice, but the complication and the follow-up sometimes is not so easy how you think. Craniopharyngiomas you have in children, you have in adults. The histology may be similar, but the behavior and the way to treat may be different. The clinical presentation also may be different. The great majority of the time is different in children and adults. But to understand the pathology, to understand the disease, have to know where this tumor come, where this tumor go. We need a very good preoperative evaluation. You used to do a plain X-ray and the calcification, the supracellular calcification that you see in 85% of the children and less than 40% in the adults is a diagnosis. With the advance of the CT scan, you can see wonderful and big mass. And the MRI show areas that is invaded that sometimes is related with the prognosis. But two very important issues in the craniopharyngiomas has to be very well described and understand. First, the endocrinology evaluation. Second, the ophthalmology evaluation. If you do a surgery, you remove the tumor, very nice MRI, and the post-op, the patient is totally disturbed with hypothalamic disease and disturbance. It does not mean that you did a good job. Sometimes the best way to treat is not to remove. Sometimes the best way to treat is do the best for the patient. The tumor can be limited to the cella, can compress the hypothalamus, can invade the hypothalamus, can go down to the posterior fossa, can go lateral to the Sylvian fissure, can go to everywhere. Because this is a way to understand the craniopharyngioma. And don't believe that the craniopharyngoma is the only one way to treat or only way to remove. Today, with the advance of endoscopic endonasal approach, looks like the world is seeing all the cases through the nose. I remember when we started to study skull base long time ago. Everybody was looking the world through the ear. It was a big incision, start here up, go down to the neck, total petrosectomy, total everything. When I arrived there, close to the tumor, brainstem invasion, they couldn't remove. Now it looks like the nose is the same route. That from the nose you can see everything. You can remove everything. And some people is saying that the only way to treat craniopharyngioma today is from the nose. But you see this nice work of Professor Steno, so that we should understand how the tumor, how they behave. We know that the only curative treatment for craniopharyngiomas is the radical total removal. Total means total. All the calcified area, all the cyst wall, and complete removal of the tumor. But it's not possible in every situation. We know that radiation therapy in different modalities work for craniopharyngoma. But in the young children, maybe the price is so high. The intracystic chemotherapy was trying many drugs, but so far is not so effective that we believe in the beginning. We know that craniopharyngioma in adults and the children are different. Is the plan to remove the facilities to dissect the structure in the adults. And the recurrence rate in the adults is much lower than in the children. You have to understand the two populations, the adult and the pediatric population, and see the way to treat them. We know that radiation works. You give time, sometimes very long rate of free recurrence, but the complication can have, and the complication sometimes is high. How I said, the intracystic therapy, we start with some drugs, we move to interferon, bleomycin, high isotopes, but no one of them had this result that we believe so. The radiation works. The tumor can disappear. The tumor can be controlled. The cyst sometimes can disappear totally. But in the number of complications long-term of radiation therapy, we need to know and explain to the people and put in balance when to do, how to do the best treatment. We know that vascular complication, cognitive disturbance, epilepsy, sometimes dysfunction hypothalamics. Radiation effect, we know today that even if the proton beam, very expensive machine that you don't have in Latin America, they have thousands in US and Europe, I don't know if you have in Africa. They have a nice result. The Braga peak gives less radiation to the borders. However, the long-term follow-up, this patient has a severe dysfunction in cognitive. And one complication that you see more and more and more is radiation-induced vasculopathy with severe ischemic disease. Almost 30 to 40% will have some episode of ischemic event with radiation therapy. But more than this, than know how to do with craniopharyngioma, you should understand you need a strategy. In the strategy, the plan is not the tool that you have. It is the tool that the patients need. This is one example. This guy went to a neurosurgeon, functional neurosurgeon, and he decided to put a Ommaya catheter and bleomycin inside the cyst and leave this solid part, maybe in the future give some radiation. And the vision improved a lot. The patient was very happy. The doctor are happy. The vision was almost perfect. After control was this. They decided to do, was okay. After start to come like this, now you have a big tumor back with severe deficit. They did bleomycin, they did biopsy through the transcranial, and tumor came back like this. Not came back, was never removed. And they sent to us to do the removal. We went from the nose. You try to remove from the nose. In the scar from the previous surgery, in the scar from the bleomycin, make almost impossible to get a radical total removal of the mass. You could clean, but one small piece was left. I missed this part here that I couldn't see to send this patient to radiation. If you had this patient before the bleomycin, the solid part was total intracellular, maybe you could do a radical removal. We know that the only curative treatment is the radical removal. Sometimes it's possible, sometimes not possible. But you cannot talk about craniopharyngoma and talk about one approach. There are two tumors that I say that they are an example for the skull-based surgery. One is the chordoma. Chordoma, you need to know, coming from the anterior, from lateral, from posterior, from inferior, from the temporal bone. In craniopharyngoma, you should know also how to approach. We know that it's a midline tumor, and 80% of the tumors, the way the tumor will be removed by the midline. Is the main approach you should do. But you cannot say to the people that is the only way to treat craniopharyngoma. If you say that, you don't understand this very old diagram from Professor Michael Apuzzo, the old book of Professor Apuzzo, the first edition. We have many ways to reach. Great majority of the time is from the nose. But we need to know, sometimes we need frontal temporal, subfrontal, transcortal, and transcallosal approach. For this, you need to understand how the tumor behaves, where the tumor goes, and do the best approach for the patient that the patient needs, not the approach that you know that the most beautiful or the nicer approach, the best video, that is the fashion approach. The frontal or frontolateral approach, the classic upturnal approach, is still today one of the safest approach to craniopharyngoma. The inferior approach, the transsphenoidal, if the patient has a big cella, you can come from the nose, or if there is extension retrochiasmatic, you can follow the tumor. Some tumors are so high that go inside the ventricle. And some tumors go to the posterior fossa and go to the lateral. You need to do other kind of approach. The frontolateral approach can be paternal approach, can be subfrontal approach, can be cranial orbital approach. Is the transylvian approach. And you use the transylvian root to separate the frontal lobe from the temporal lobe to do the surgery. Look at this case here. This case was proposed to this 13-year-old boy. A transclival approach. Remove the clivus, remove this part, and leave this small part in the sylvian fissure to radiosurgery. It was proposed for this guy. He came to us, you decide to do the simple way, as Professor Yashar Mills taught us many, many years ago. You decide to come by transsylvian approach, open the sylvian fissure, dissect the arachnoid. You see, in the end of the sylvian fissure, you can see the tumor already. You can totally separate with microsurgical technique, very short instrument, very stable hands. You can dissect, liberate totally the frontal, liberate totally the temporal, drain the cyst, and go follow the tumor. See? Just follow the money. How do you have to take the people from the mafia? Follow the money, you catch the guy. Just follow the money. Follow the cyst, follow the tumor, and go dissecting very short instrument. I use this pattern you see here, but I open the sylvian fissure. If you open the sylvian fissure, you liberate, you can do the surgery safely. And look this here, the carotid artery and thoracic border. We are separating the wall of the cyst. We remove it. Look the cyst that is in the posterior fossa. That was proposed to the guy to do a transclival approach. Look at the cyst there. What's safer? What's easier to us as a neurosurgeon? To open the sylvian fissure, microsurgical technique, identify the third nerve, the carotid artery, and the basilar artery, and remove the cyst, or drill the clivus and come from the nose. The people that do from the nose, this case, they say, oh, you are touching the optic nerve. I know that you are coming from the nose, you're not touching the optic nerve because you're not seeing. The optic nerve is superior to it. Here you can do very short dissection, very precise dissection, and preserve the pituitary stalk. This is a controversy, in pituitary stalk. The people say that, oh, I preserve the pituitary, I try to preserve the pituitary stalk in every case. Try, but the tumor is coming from there. Your index or recurrence will be higher if you preserve the pituitary stalk. If you have doubt, you have tumor in the pituitary stalk, maybe for the patient, it's better to cut. See? You can remove this cell by cell, piece by piece, is the way, at least to try to avoid recurrence. Does not mean that it's total, is radical, just the follow-up will say that will happen, and the pre and the post-op. You have a tumor like this, same situation, big cyst, calcification around the vessels. Not easy to remove. Sometimes you do the surgery, do the maximum that you can, that you cannot remove all the calcifications. And the tumor can come back in very close watch. It's very important in craniopharyngiomas. Very close watch. Follow the patient. Sometimes it is a big recurrence with very few symptoms. You see here, you can clean, see all the anatomy. You can, looks like perfect. See? You preserve all the structure, frontal lobe okay, temporal lobe okay, Sylvan fish in the middle, post-op, the guys here, the ladies, the young, they see. Very nice, yeah. 1 year later, boom, went back. The histology was more aggressive in that craniopharyngoma than the young lady. There is situation that the tumor gives the approach for you, and the tumor gives the root for you. Look at this. A big room, big cell, and big sphenoid sinus. Wide approach. The tumors come from the back. Retrochiasmatic. It's easier to come from here. This way you can do by endoscope. I use a lot microscope with endoscope in the end, because I train a lot with the microscope. I feel more comfort with the microscope. But if you are starting transsphenoidal surgery, I tell you that you should do with endoscopy. You see to have better view, you understand better. I use both. Tell you that I feel more comfortable with the microscope, but I use a lot the endoscope to see in the corner. But understand this. If you buy an endoscope, you don't become magic. You don't become the best surgeon, endoscopic surgeon in the world. It's a tool, and use the tool as a tool. The endoscope gives you a view that you never imagined you could see. You could see in the corners. You never see these corners. Now you can see easily. See? You can see in the corners, look around here, look around there. With the microscope, you cannot see this. This view you never have with the microscope, you have with the endoscope. It is very important. But you need to use all the tools that you have. Sometimes the microscope help you, sometimes the endoscope help you. You need several instruments. Suction, curve suction, dissection, embionate, straight, endoscope, microscope, and go ahead. Tumor like this, young boy, I did the called transcolumellar approach. Young boy, just open the columella here in the middle. It's an old case. Today, maybe I do only if endoscope, no microscope. But with training, you could do it. But if the endoscope, you help with this. This view, you have the endoscope. You can see, you can dissect, you know where you are dissecting. You separate totally. The wall is adult, okay? There is better wall. Separate the area, you dissect the tumor, you can preserve that. In the end, you put the endoscope, you see everywhere. This view from the endoscope is wonderful. You don't miss tumor in the lateral part, not so lateral. The sixth nerve is the limit, you know? But the sixth nerve, the distance between the both sixth nerve is 8 millimeters. Looks here, you have a view like a big avenue. It's not big avenue, it's 8 millimeters, the maximum that you have. And the tumor that we have in our country, is much larger than this. Other situation like this, same situation, in this case I did with the microscope. And you come, you change the scissor, send the microscope, and the post-op. The tumor gave this approach for you. But sometimes the situation is different. Look at these two guys. One, it's based in the work of Professor Steno. This tumor here, calcified, solid part, cystic. Here, cystic, solid. This patient has no endocrinological dysfunction. This patient has obesity. This patient came early to me. I decided to do transcallosal. If I go transcallosal, I just follow the tumor and go from the midline, go down. We did the surgery. You came transcallosal. You remove the tumor transcallosal. It was a big mass also. You decrease, but see, look at the size of the mass. It's coming cheap. You just followed it. You see, who did this dorsum sella? Okay, is basilar artery. I didn't dissect this. The tumor dissect to me. It's the sixth nerve down. I just follow the route that the tumor gave to me. See, it's the pituitary stalk where the tumor was coming. Very nice view. Just follow it. See, basilar artery, the whole brain stem. But the solid part was superior. I follow from the solid part that open the hypothalamus and give me the way. In the pre-op and the post-op, a nice removal. Same situation like this, young children, cachexia, very nice tumor. I scan from the superior part and get a nice removal from this. Just follow the tumor. And I was thinking, I found a way. Big tumor, transcallosal, very nice view, total control of the vessel. Let's do this way. What's happened in this situation here? What's the difference here? The hypothalamus was up. I did the surgery. Very nice post-op MRI. Clean. The presentation is wonderful. To show in meetings and Congress, very nice. The people say, oh, very nice approach. What happens to this patient? 60 days in the hospital. Severe hypothalamic disturbance. To know why? I came through the hypothalamus. What I learned in this case is this. When the cyst is superior, the great majority of the time, the hypothalamus is displaced superior. Today, how I do this case? From the nose. And come from the nose. Open wide the cella, open the anterior wall, open and follow the tumor in the retrochiasmatic way. This way, the hypothalamus will be displaced superior. But you have craniopharyngoma like this that you use, I know that you have in Morocco, you have in Africa, you have in South America. Look at this. It's going to everywhere. Lateral side, contralateral side. And my mentor, Dr. Omefti, say, when you don't know how to do the approach, if anterolateral, do cranioorbital zygomatic. When you don't know how to do in the posterior fossa, do transpetrosal. You open the view. You have retrosig, anterior petrosal, posterior petrosal, drill the temporal bone. This is the idea of Professor Hakuba. See, in 85, he described this for retrochiasmatic craniopharyngoma. Today, the great majority of retrochiasmatic craniopharyngoma you can do through the nose. But that time there was no endoscopy. This was the way that he decided. And the idea is very nice, but you're coming from below. And you see from below and from behind. You can see the floor of the third ventricle. You can dissect easily from the floor of the third ventricle. This Dr. Omefti published in 2007. It's very interesting that they say, I commented this paper, me and Professor Evandro de Oliveira. It's a very nice approach, but it's difficult to find the case to do it. We found the case. The young guy, that big tumor that's going lateral to bilateral, you came from here. And you exposed and showed all the area. But independent of the surgical approach that you use, independent of the microsurgical technique you use, through the nose, through the sylvian fissure, through the temporal bone, through the transcallosal, if you don't have a very nice ICU, you will lose the patient. The post-operative care is one of the most important pillars in the treatment of craniopharyngoma. You lose the patient, and you need control to avoid hypernatremia, hyponatremia, hyperthermia, and severe disturbance. We know today that despite of your microsurgical technique, the recurrence rate for craniopharyngoma is still very, very high, almost 40%, despite of the best microsurgical technique in good hand. This is a number 64 patient here. Very interesting that they show that from the para and retrochiasmatic and the retrochiasmatic tumor, the transsphenoidal is much better than the pterygium approach. It's okay. The tumor is behind, you cannot remove it, but the recurrence is still very, very high. Because this, if you do surgery, if you have a nice removal, maybe clean the MRI, maybe you should wait one adjuvant treatment of radiation therapy for these young children. I always finish with this. It's common in Brazil. This changed the history of craniopharyngoma. Hormone replacement. Without hormone replacement, there is no good neurosurgeon for craniopharyngoma. Without training in the lab, there is no good neurosurgeon. It's no more acceptable we are trained in the head of somebody. It's the time that you should go to the lab, learn all the neurosurgical approaches, all the techniques, understand the anatomy, follow good teachers, follow your master, but understand totally the anatomy in the lab. Neurosurgeon today is make not only in the OR. Neurosurgeon today has to make in the ICU, but also in the microsurgical lab. Thank you very, very much, and sorry for the long time. Thank you.
Thank you very much. Thank you very much, Professor Borba, and for this excellent, as always, excellent talk. I invite all participants to ask their questions directly to the three speakers by the end of the talk. So I give the mic to Professor Amjid Chilawi to introduce Professor Najir Abadi. Professor Amjid Chilawi is the treasurer of the Moroccan Society of Neurosurgery, and he's professor of neurosurgery at the Ibn Rushd Hospital in Casablanca. You have the mic, Professor Chilawi.
Thank you, Dr. Fad. It's a huge honor for me to be here among the masters this evening. So on the behalf of the Moroccan Society of Neurosurgery, I would like to thank all the speakers for the high scientific quality of their talks. And now we will move towards the third speakers, who will be given by Professor Najir Abadi. So before starting the presentation, let me introduce you the Professor Najir Abadi. So Professor Najir Abadi is professor in neurosurgery since 1990. She was professor and head of Department of Neurosurgery at Ibn Sina Hospital in Rabat since 2030. Currently, she is the head of Department of the Neurosurgery of International and University Sheikh Zayed Hospital. She is the chief of Department of Surgery at Apoplexy University since 2016. She served as assistant secretary in 2005 in the World Congress in Marrakesh. She was also the chairman of WFNS Women in Neurosurgery Committee from 2030 to 2017. She is also the past president of the Moroccan Society of Neurosurgery. Currently, she is the assistant treasurer of WNFS and president of the Pan-Arab Society of Neurosurgery. Also founder and past president of the Mediterranean Association of Neurological Surgeons. Professor Najir Abadi is the director of stereotactic program in the medical school in Rabat. Is interested in vascular surgery, especially of the brainstem, school-based stereotactic functional surgery, and spine surgery. She's also involved for many years in training of African students in neurosurgery in the field of the program 100 for Africa and WFNS Rabat Reference Center for Training of African Young Neurosurgeons. She is the author of over than 100 scientific publications in international and national journals, as well as chapters in books of neurosurgery, and more than 500 lectures and presentations at international and national congress, and the chief editor of the Moroccan Journal of Neurosurgery and reviewer of neurosurgery. Well, this was just a few words in a big career, and her perseverance and her enthusiasm inspires many women in neurosurgery speaking in the Arabic world and Africa. She also occupied many prestigious positions in the functional and local and international instances. So please welcome Professor Abadi. Thank you.
Thank you, Professor Amjid Chilawi, for this really very kind word to myself. It's very hard and not easy task to speak about after Professor Caldwell and Professor Ruiz, but I will take this challenge as neurosurgeon, so I will try.
my best to give you my to share with you my experience about this type of meningiomas, which is located in anterior skull base. So all of you knows that this location of meningiomas represent a real challenge, as I said, for neurosurgeons, because the high relationship between the neurovascular structures and the tumor, especially when the size of this tumor is very important, such as of the most cases of our series in Morocco. But I discovered today that not only in Africa, in Morocco, but also in USA, and it's such as Luis showed us in Latin America. This region is very particular, is very challenging surgery. So concerning the epidemiological aspect of this location of meningioma is this variety represent about 10% of meningiomas, and they are usually big when they diagnosis, and they are benign but high rate of recurrences comparatively to other locations. And let me share with you our series since 2005. It's about 154 meningiomas of anterior skull base, and this many classification, as you know, are published in the literature, and all of them join the Cushing classification according to the anterior skull base location. There are some in middle line, the others laterally, as is shown by our my predecessor. Is this region is very particular. So we will go over many this different location. I will start with the ethmoidal of frontal ethmoidal olfactory growth meningioma, it's called also. And this first one kind of location represent 8% of all the anterior skull base meningiomas. And this in this CT scan shows the implantation on the crista galli, which is partially calcified. I think I can use my, and you see the important perilesional edema, and frequently they could be bilateral, sometimes symmetrically as is shown in this MRI, or develop mainly on one side, but you can see its impact on olfactory growth and on the compression of the frontal lobes. You can even see the erosion of the skull base on the CT scan here in the left of the slide. Exceptionally, they could be cystic, as is shown here. The second variety is the jugum sphenoidal meningioma. This head X-ray is really very ancient X-ray, show a meningioma of tubercle celli which extended to the planum sphenoidal with blistering of sphenoidal sinus. And on MRI of this same patient, you see the meningioma high isointense that compresses the frontal lobes and spares the chiasm. The second case is shows a big tumor with important perilesional edema. The third and fourth variety of the middle line of this anterior skull base is the tuberculum celli meningioma and diaphragm meningioma. They represent around 6% of meningiomas. The first case shows the difficulty to identify the real insertion, and it also shows the tumor englobing the arteries of anterior circle of Willis. And sometimes the pituitary stalk, this can be predicted preoperatively the hard management of these tumors and the high complication rates. The second case represents a medium-sized tuberculum celli meningioma that we can't specify its extension into the sella turcica. It has no edema. However, on the MRI, the limits are distinguished easily, showing the diaphragm celli between the tumor and the gland. And you see the enhancement of the tumor and the chiasm deviated and compressed, but it is not the frequent situation. Most of the time, per-operative consultation, is the per-operative consultation to know the insertion of this type of meningioma. The third case shows hyperhastosis of the midtuberculum planum and a part of sella. On the MRI, hyperhastosis tumor and gland is, you can see it here. So the other diaphragm typical finding in the diaphragm cella meningioma is there are 3 types, and this is described by many authors, specifically by Professor Osama El-Mafti. The type 1 is originating from the upper leaf of the diaphragm cella anteriorly to the pituitary stalk. This is usually give unilateral visual disturbance and visual field defect. The type 2, it's come from the upper leaf of the diaphragm cell posteriorly to the pituitary stalk, and this causes a fewer visual disturbance, but there is more than memory disturbance and hypopituitarism occur. And the type C is originally from the inferior leaf of the diaphragm cell. It's clinically the finding, final clinically finding is bitemporal hemianopsia and hypopituitarism are very common in this patient. The other location laterally of this anterior skull base, it's sphenoid-rich meningiomas. They are classified into three groups. The first one is the difficult one, challenging one is the deep anal medial in the clinoidal type, and in this type there is two subgroup was described by Osama El-Mafti: lower clinoidal, superior and lateral clinoidal, and optical canal. And the second type of the sphenoid-rich meningioma is alar or mid.
With the sound.
They are osseous tumor, the bone. They cause significant hyperostosis. The tumor spread like a carpet is shown here, as you see. And the tumor involved lesser wing of the sphenoidal bone, orbital cavity roof, lateral wall of the orbit. Sometimes the bony part may included an anterior clinoid process, superior orbital fissure, optical canal, and sphenoidal and ethmoidal sinus in sometimes. The last one is the cavernous sinus meningiomas, as a very challenging also kind of meningiomas in this location. And this tumor may start inside and spread outside, or start outside the sinus. They could be involve very vital sinus neurovascular structure as the carotid artery, and could be also involve optic nerves, chiasm, involve pituitary gland and stalk, and sometimes also the sphenoid sinus, clivus, petrous bone. They can go, as Louis said, in the whatever direction. So we need many armatorium in this type of surgery and skull-based surgery globally, but specifically in this medium and medial and lateral skull-based meningiomas. Of course, to be cool neurosurgeon first, and high-speed drilling, high quality of microscope, endoscope, neuroendoscope, and many other tools. Neuronavigation, I think, is not really mandatory in this type of surgery. And there is some principle of meningioma surgery that you know all of you very well. Always look for the cranial nerves, the circle of Willis, artery branches, perforators, to look after pituitary stalk, hypothalamus,
focus on preserving the function and avoid to induce brain retraction. Don't touch the veins globally. And the gold standard, we know that of this treatment is surgery, of course, but that should be done wherever is possible with low morbidity. These tumors are usually hemorrhagic, so we should plan transfusion to reduce the bleeding. And we should always start by the insertion zone and perform the resection en bloc when the size of tumor allows it. But in our context, is very different and is very rare. You see on this this video, you see in this video the coagulation of nourishing pedicles. But if the tumor is huge, we need to start by debulking it first, and sometimes shrink it by bipolar, as we do here, and removal by fragmentation. For this surgery, we need a maximum of tools, as I said before, and ultrasonic aspirator maybe sometimes, and laser can help us in this task. And some author use neurofugation, but I think it's not, in my opinion, it's not mandatory. So the target of surgery is, of course, the total removal, but the preservation of the function, avoid the injury. Injury, especially of the vascular structure, but also of the functional optic nerve, chiasm, and the pituitary stalk, olfactory nerves, as is very well shown by Professor Caldwell and Professor Borba. It's very important to deal with this region and their complication. I have the part, the very easy part is the meningioma in this region is the best and is the more difficult, less difficult than the others, Craniopharyngiomas, for example, or others, other type of tumors. So we need to know before to start in this surgery, how is the chiasm, how is the optic nerves, the anatomy, as already said, is very important. Is the knowledge of the good anatomy is the basic of this surgery. And you see here when you have, for example, the normal chiasm in 84%, but sometimes we have the prefixed chiasm or postfixed chiasm, and it could be very difficult when there is this, when the situation is like look like this this type of course achieve the total removal of the tumor, especially in his insertion. So what are the main surgical approaches we can use to reach the tumor of this area? It already start, we can use many of course approaches, but let me start with the bifrontal approach. Just first of all after the flap bone, we start with exposure and control of superior sagittal sinus. And the advantage of this approach are large: control of the dural implantation, resection of the dura during the bone when there is, of course, invasion of the bone, and inconvenience of this approach are opening of the frontal sinus, which exposed to sometimes to infection, late control of posterior part of tumor, and more cerebral retraction, and condemn the olfaction in this approach. Here is a CT scan of 54 years old woman operated by this approach before and after surgery here, and with a good outcome. So unifrontal approach, still frequently used as already shown by my predecessor, and it's one of we usually use, but it depends on the size of the tumor. The advantage the advantage are a respect of contralateral frontal lobe and the sagittal sinus. Inconvenience is our narrow approach sometimes when the tumor is very huge, and more traction on the frontal lobe of in the side that we choose. I will show you some cases where the unilateral approach was performed. It doesn't work. I don't know why. Okay, so I will show you some cases. I just said where this unilateral approach was performed. This third case is of meningioma of sphenoidal planum, little bit bilateralized on the right side. You see on the unfortunately my video doesn't work. I don't know why. Sorry. Is the middle? The middle is here is the medial part, and here is the cranial base. This is implantation of the tumor here, and we start by coagulation of this implantation insertion and removal by progressive fragmentation of the tumor. And see the frontal lobe here without retraction is not the frequent situation. Doesn't work. Oh, finally it worked. Just to see here the insertion of the meningioma here, which is coagulated before, and we remove totally the tumor. So this is a very interesting case. A 40-year-old woman, which we diagnosed 1 year later. The patient refused the operation. When I saw her, she had the glass 9. The tumor size was more than 10 centimeters with bilateral and posterior extension. So we start firstly by unilateral and reduction of the tumor. After clinical improvement, we performed the second operation on the other side, and she felt better after 3 months, but there was still a residual fragment posteriorly, as you see here in this this CT scan, post-operative CT scan. And maybe the radiosurgery will be proposed for this control of this residual fragment, but we could be criticized for using a unilateral approach first, but it was used for the decompression only. And unfortunately, I don't see her for the two or 3 years now. This is one of the difficulties that we have, we are affront of in our country, is sometimes losing the evolution of our patients. This is a case diagnosis of giant aneurysm. Look here, and of anterior communication, anterior in an MRI, of course. But we will see here in this film that it's surely meningioma with the adherent fragment to the carotid artery here, and which obliged us to leave this part of the tumor, just the carotid artery, as you see here in the CT scan, this small residue here. So when the lesion is in the middle line, this approach is not indicated. It means the terminal approach. Even if we open widely, the Sylvian fissure is not indicated because the control of the posterior pole of the contralateral side is very difficult and hardly reached. You see here on this CT scan control here, showing the partial resection and the difficulty to achieve it, and of course the frontal lobe is there is a contusion. And this is another cases of management of sphenoidal or sphenoorbital here. And here, look, the huge invasion of the bone of the orbital bone and the sphenoid bone. And this is another cases we can achieve even if there is invasion of the bone, the total removal with the removal of the lateral wall of the orbit and the sphenoid bone, and also in a large part of the compartment of the orbit. And here, this is one of my favorite approach. It's frontal orbitonasal approach. We found it preferable to the bifrontal approach for gaining low basal exposure and for removing the upper portion of the giant meningiomas without brain retraction. And this approach present here has the advantage, first, to minimizing the retraction on the frontal lobe, second, bridging veins, and thirdly, interrupted blood supply to the tumor early in the procedure, and also optimizing internal decompression of the tumor and offering direct access to both sides and the posterior and upper aspect of the tumor, permitting extra arachnoid excision and facilitating resection of the dural origin and sometimes any bone lesion associated. This is two cases. This is the wife of our anatomopathologic in this case, and in this case we performed less than 1 year now, and this is the control with the complete removal. This is the one of the difficult also and challenging surgery is the wing of sphenoidal wing. And here is the third type is inviting the carotid artery here, and this is the I lose my video unfortunately, so I have just some views, but it's not really very it's confusing. You see here the optic nerves and here the meningioma. So what about the endonasal endoscopy resection? I will not go over because it's not in my, I do of course endoscopy for pituitary and adenoma, but I have not really experience about meningioma, especially in the anterior skull base. I did only 2 cases from sphenoidal jugum, but it was very small meningiomas. I didn't have really experience with endoscopic endonasal for this type of tumor. So, can we predict the quality of the resection? Let me show you these cases when the answer of course for this question is usually no. We can predict, as you saw shown is this case, a medium size of planar meningioma. We thought firstly that at first that operation can be performed very easily, and we can achieve the total removal. We did more giant tumors, but we were very astonished when we was in per-operatively, because we ended up the operation and leaving a remnant, as you see in this CT scan here. Lasted stable on CT scan, and it's lasted stable during 6 years now of control. So do we have to offer him a radiosurgery maybe in the future? Till now she's under the control. So complications are seen in 30% of patients, among which neurological defect, infection after CSF legs, or opening the especially when the frontal sinus is open and epilepsy, etc. We don't observe any death in our city. It's curious, but it's like that. Sorry, and but the percentage of that is about 4 to 18% in the literature, and the recurrences is about in our city about 6%. But as I already said, it's difficult to say that we have only the rate of recurrence, because some of our patients are we lose some of the patient for the control. So the gold standard is surgery, as already said, but which complete resection should be made. Of course, the main aim with low morbidity. But or unfortunately, due to the importance of the stricture in this area, this aim is often hardly achieved. This is the reason why it is unacceptable nowadays to conceive severe morbidity that can be skipped by our complementary radiosurgery that is efficient on the remnant of meningioma. The skull-based meningioma represent a bad prognosis factor. Combined treatment and complete microsurgery, and sometimes when we can't achieve it easily, and surgery after is recommended each time. That science Latin sentence, primum non oster, the art of cure without damaging or under all its forms. So how about radiotherapy? All the authors in the literature and said we should to use radiosurgery for remnant of meningioma, and no more radiotherapy for benign tumor, especially for the meningioma. So in conclusion, resecable progressive meningioma with low functional risk should be removed. A big-sized progressive meningioma, which the complete resection can induce important functional risk, should be discussed combined approach at the beginning. Partial resection accomplished by radiosurgery. And before to thank you all of you to be with us today, I would like to just to remind you about our next African Rabbi Reference Center course for African young neurosurgeon in 1 month and a half. It means at 19 November. And I hope that you will all you will be with us for this webinar, for this course, even if virtually, of course, and this hard time. Thank you so much for your attention.
Thank you, Professor Abadi, for this excellent didactic presentation concerning meningioma of the Ontario School base. And I think we can now move for the session of question.
Lawi?
Oui, Professor Azari.
Thank you. Thank you for all organizers of this very nice webinar, including our friend William and Luis, and I will congratulate Moroccan Society for this series of webinar, all the committee and the President, Professor Lakhdar, and thank you for William and for Luis. Just I have one comment, and for Luis, I like your philosophy. Really, I like your philosophy. Craniopharyngioma. Craniopharyngioma is a disease. It's not a tumor. It's a disease. It's congenital disease. It came with the patient. So, is the good neurosurgeon, the best neurosurgeon can have, if he don't know how is the neurologic consequences of this area, it should be catastrophic. I remember one patient, he was a colleague in Casablanca, and he graduate his specialty, and just after graduation he has some headaches, and in this time, it's more than 10 years, He has a CT scan, and it was craniopharyngioma. He went to Paris. He was operated by one of the best neurosurgeon, Professor Philippon. And there was it was a total removal. It was everything was okay, and he come back to Morocco and he worked. He was the pneumologist, and after 3 years, there was a recurrence, and the recurrence was posterior in hypothalamus, and he was operated for the second time in Paris, but he developed one syndrome, hypothalamic syndrome. It's very huge, with polyphagia, with polydipsia. He take a lot of weight, and he was very, very low, and for many months, and he died at the end. That is the question we should have in our mind before be total, before be good neurosurgeon for total removal. As you said, the Professor Khamlishi, our mentor, said he's specialist of craniopharyngioma. When he see every conference or every surgery of craniopharyngioma, he has always one question: how are the results? How is the patient after removal removal of craniopharyngioma? So it depends in the location, of course. There was some craniopharyngioma. As you said, Luis, you follow the tumor. You don't go laterally or posteriorly. I have sometimes a good chance to remove it behind the communicating artery in the lamina terminalis. Sometimes there is a very good way, but it's not always the same time. So now the philosophy is there some, the hypothalamus, there's a small nucleus. It's very, very vital. And if there is a small lesion in hypothalamus, it's catastrophic. So the question is, can we just make free the optic pathways and all the structure around? And if there is some small pieces superior going to the third ventricle in the hypothalamus, there is no radiosurgery. And radiosurgery could perhaps help to complete the treatment, because the treatment of craniopharyngioma is not or every tumor, it's not total removal, but to treat the patient and to let him in good condition of life. That is my comment, and thank you very much for all speakers. It was really very interesting. Thank you.
Thank you, Professor Lazari, for your comments. I don't know if you have, we have some question. Yes, Professor Khamlishi, please.
Thank you very much. Do you hear me?
Yes, excellent.
Yeah, first, my deep thanks to all our group, the organizers, for such a very nice webinar. And of course, special welcome to our guests, Professor Gordwell, Professor Borbach. I'm very happy to see both of them here. And I think that we had a very interesting, very important talk about three groups of benign tumors, which of course have some differences, but almost arise the same challenges. And my question to three speakers is, of course, you have shown a lot of large and giant tumors. The problem for me with this group, three group of tumors, is when they are large and when they are invasive, not when they are encasing the neurostructure. It's really different. Encasement is completely different than invasiveness. When they are encasing, you can maybe manage to dissect most of them. But when they are inviting the pia of the nerve, when they are and the cortex, when they are inviting the advantage of the vessels, this is a real problem. So how you manage this group of large invasive tumors? They represent maybe less than 20%, around 10 to 15%, but how you manage that? And I think this led me to another comment regarding what was said by my friend and colleague Abdsamad Al-Azhari regarding the risk in craniopharyngioma, but also in other large tumors, of course, more in craniopharyngioma. Do you think, this is my second question for three also speakers, do you think that it's still necessary to continue to do all our possible to resect completely the tumor? I believe personally on the radiosurgery as adjuvant treatment. We have got our unit of radiosurgery since now 12 years. And believe me, I can tell you that it's very efficient in remnant tumor, either craniopharyngioma, pituitary adenoma, or meningioma. So I think that we have to say to our young people to try to stop when of course it's hazardous, and we see that maybe we are going to get a harm for the patients. Thank you so much again for this excellent lectures, and I'm very happy to attend this webinar because the three topics are ones of my favorite surgery. Thank you very much for all the speakers and the organizers.
Thank you, Professor Khamdishi. Now would like to answer.
May I say something? I don't know if Dr. Calder is around. Okay. First of all, it's a great pleasure to see you again, healthy in this time. The pandemic make us no more meetings, presential, but the whole world is together today. Today we can talk to the whole world, and this exchange of experience is very, very important to us. Do you know, Professor, what you are learning of the time that you should understand the disease. And when we talk about craniopharyngioma, we know that the only way to cure, theoretically cure, is radical total removal. But it's not possible in every case. We know that the first time is the best time. See, if you try for the first time is your big chance, because the recurrence craniopharyngioma, the reoperation craniopharyngioma is very difficult, very difficult. A lot of adhesion, is scar, is almost impossible to remove. Of course, if you have one area that is away from vital structure, you can take it. But in the great majority of the time, the piece that you will leave is close to the hypothalamus, was very important structure. Because the first time is the best time. What I'm a little bit not worried about the happening today, that it looks like the people talk about craniopharyngioma just one way to reach, have to go to the nose. No matter you go from the nose, you can take everything. There is no complication, the nose CSF leak. Now they have the flap. We need to understand the best way to go around. And you need to understand also that sometimes you cannot take it. And sometimes it's better to leave. See, for some pituitaries, the radiosurgery works. For craniopharyngioma, the radiation therapy works. But sometimes our children, you cannot give the radiation, or if you give the radiation, you have consequences. See, tailored to each case and understanding with experience, if you're changing the way to think. Do you know, I remember the Professor Calder here has a lot of experience in cavernous sinus meningioma. And when Professor Dolenk in his era started to do cavernous sinus meningioma, was total removal in everybody. And the whole world was doing total removal in everybody. After that, they knew that they have more complication than total removal. Now you are thinking in natural history of the small cavernous sinus meningioma without optic nerve compression. You are understanding the disease. More you understand the disease, better will be the treatment. In craniopharyngiomas, you understanding today that if you want to do radical, in case that you cannot do, of course, if you go there, the tumors come out easily from the hypothalamus, it's okay. But sometimes you cannot. It is difficult to predict it in the pre-op sometimes. The price that you pay for this young boy is so high that sometimes not worth. I think judgment and white hair make you think a little bit different when you started. I don't know. I don't know if I have more.
Thank you, Professor Bomba. Don't know if there are other questions.
I can ask a question?
Yes, of course, Professor Tofir,
Yes,
please.
yes, please. Thank you very much for those presentation, magnifique and wonderful and academic lecture. Thank you for Mr. Caldwell, Mr. Borba, and Professor Al-Abadi. Thank you very much. I have some question first for Mr. Borba. Mr. Borba, about pituitary stalk, is it must to cut in each time pituitary stalk during craniopharyngioma surgery? And if not, is there perioperatively criteria to help us to take decision about this? And the second question is regarding the hypothalamic injury. Is there difference between transcranial and endoscopic approaches? Thank you.
I start for the transcranial and endoscopic. The retrochiasmatic tumor, you can see much better when it's coming from below, or from here, or maybe from here. Dr. Omefti, you're using the petrosal, you can see from below. But the dissection and the damage of the hypothalamus sometimes is unpredicted in the pre-op. Sometimes you don't know if there is a real invasion like fingers or if you just touching. I don't know if somebody can help me in this. If there is an MRI findings that is say that if there is real invasion, there is just compression. It's difficult to know what real invasion. The other things about the pituitary stalk. I say one thing that the people today is not saying. No. Everybody's preserved everything in everything. Everybody has no complication in everything. If the tumor is coming, is invaded the pituitary stalk, if you remove totally the tumor, you are sure that you remove totally. This is a small tumor, you remove. If there is a small tumor in the pituitary stalk, if you are sure that you will cure that patient, maybe you should cut and remove and do hormone replacement. See, because sometimes you preserve the stalk and it's not working. But if you can preserve the stalk, you can clean. You see that it can work. It's better to preserve. but it does not mean that you have the function completely okay in the post-op. I want to say one thing about the radio surgery. Do you know what's happening in my country, Professor? 70% of the radio surgery is making by radiation oncologists. The neurosurgeons are not involved. Sometimes they have some agreement to send the patient to the radiation oncologist. I think that radio surgery is a neurosurgical business. It's not a radiation oncology business. But the problem that maybe the people start to kill the method. Take acoustic neuroma like this and say that you can do a surgery with adaptive hybrid, something like that. I don't know how's the word. That the computer will say to you that you remove this, but you can leave this small piece. I don't know if it really works. You should use the methods. You should do the radical removal when you can. You should do the radio surgery when you need. See? Because this has to be with the neurosurgeon. But in Brazil, not possible. In Latin America, not possible. Because gamma knife, you have just 2 in the whole country. Linac, you have hundreds. And who pay the machine for the Linac is the other pathologist. The neurosurgeon is not involved in the business. See? And they do whatever they want. This is the problem to us with the radio surgery. It's not the methods and who is doing and the indication for this. Is the only, I don't know if I answered your question, Tufik.
Okay, thank you. Thank you, Mr. Borba. One more question, if possible. What is your experience with the anthracistic therapy? And what is your opinion about this kind of treatment? Still has its place in therapy today?
I don't have experience, but I learn of the people. One of the first people to do bleomycin was a Brazilian guy, bleomycin and interferon. In bleomycin, man, they kill a lot. They kill a lot of patients. They inject some arachnoiditis, meningitis, severe disease with bleomycin. Interferon, I don't know, maybe Professor Calder can help me. The primary work was okay, but I think today is not working. The people are not using tomorrow. They're using radioisotopes inside, but the result, I'm not sure that is so good, I will say. Let's comment. We have a webinar about craniopharyngiomas a long time ago, 2 months ago, and Dr. Boop, Frederick Boop, a great friend of us, he is working in Memphis. He has a lot of experience in craniopharyngiomas. And he was showing the cases in one guy that was watching, make a question, see, I'm working in a very poor country, that he said was in Africa, but could be in South America also. That they only have patients that come with very small, young, cachexia. They cannot do any kind of surgery. We put Omaya in the cyst and drain, and the people improve the intracranial hypertension and go. The young boy. You know what the answer of Dr. Boop? In his series was the best patient, was the best cases. That you are giving time to the get weight, replace hormone is going better. You see? There is no answer for many things. There is no answer for many things. See? Okay.
Thank you.
Okay, thank you, Mr. Borba. Thank you.
Thank you.
Thank you.
We have some question from the audience. One question is for Professor Naji El-Abadi. How do you manage osteoma in meningioma, in school-based meningioma?
Yeah, I saw the question before it. It's by drilling. I know it's not easy sometimes, especially when in the type of sphenoorbital, and sometimes when the invasion of the orbit is very important, huge, is very difficult. We need to drill in all the osteum, all the bony, which was invited. Sometimes we can succeed to achieve that goal, but I show you one case. It's really very spectacular, and we can do it, but it's not easy to do it every time. I know it's not. But you need to drilling when the most the invasion is in the orbital. In the lateral wall is no problem. You can reconstruct after for the superior orbital roof also, but when all the orbit is invaded with the exophthalmia, it's very difficult to achieve the total removal. Sure.
There is also another question from the audience concerning, it's this time to Professor William Caldwell, I think, is suggesting transcranial surgery more on COVID time.
Yes, yeah, I saw that question. So the way we do, how we decide if we do surgery in COVID times is if the patient needs to have the surgery, like if it's, we call it time sensitive, it means that we can't leave them for a long time, we just go ahead and do them. But if they're COVID positive and they can wait, then we wait 10 days and then do the surgery. And we don't retest, we just go ahead and do the surgery 10 days later if the patients are feeling well. But we basically decide if the patient can wait or if they can't wait. And then we do emergency surgeries on COVID patients, aneurysms, that type of thing, if necessary. So we make a decision. Can I, Tofi, can I just make a couple of comments about craniopharyngiomas? And,
Yes,
so,
sure.
big craniopharyngiomas, in my mind, petroclival meningiomas and big, large craniopharyngiomas are the most difficult cases that we do in neurosurgery. And that includes all aneurysms, bypasses, everything, because they require the most judgment, as Lewis alluded to. And I think that the patient outcome is really dependent on the judgment of the surgeon and how aggressive they're going to be. And we try to be as aggressive as we can, but we're very, very careful of the hypothalamus. I'm less worried about the pituitary stalk, because if we think we can cure the patient by taking the stalk, we'll do that. But it's the hypothalamic invasion that we've really got to be careful of. And so I appreciated Lewis's comments. And then one other comment I wanted to make, Najia was just talking about these sphenoorbital meningiomas. We have a large series of these, and we published some of them in the Journal of Neurosurgery a few years ago. But we've become very aggressive about removing all the bone, the hyperostotic bone, because as Sam El-Mefti taught us many years ago, that thickened bone is tumor. Tumor is in the bone. And so they'll recur in the orbit as well. And the surgeons need to be comfortable with opening up the orbit, and we'll peel the periorbita down if it's involved with meningioma as well. Because I have a series of these patients that have recurred time and time again, and they've been radiated, gamma knife, everything. And then you have to do a big exenteration and reconstruct the carotid and the tumors in the cavernous sinus. So in some cases, I think it's better to be more aggressive early on to try and reduce the dangerous recurrences down the line. And I have a series of patients that are like unbelievable cases where we've had to do resections of hemifacial resection and this type of thing, and then get free flaps where people have had small operations for sphenoorbital meningiomas, and they've ultimately recurred and become real problems. So I just wanted to share those thoughts.
Thank you, Professor William.
Thank you.
I think we have a question from Fahd.
Professor.
Thank you. My question is for Professor Borba and Professor Caldwell. So Professor Borba told us that we should go to the lab for cadaveric courses. Unfortunately, in many low and middle income countries, we don't have this opportunity. We don't have cadaveric labs. And I will not ask him if you ask him and ask Professor Caldwell if we want to advise someone, young neurosurgeon, to go to a cadaveric lab. What are the best 5 courses to put on the list, on the packet?
Yes, I mean, it's becoming more common now. Like we do a course in Egypt. We didn't do it this year, but we do it in the military hospital in Cairo with cadavers. And so some Arab countries now are becoming, it's more common to use cadavers. But there are many courses in America through the INS that are cadaveric courses. And we've done courses in India as well, and many cadaveric courses in India as well. There's a lot of opportunity there because they're very liberal with the use of the bodies if they're not claimed, if the unknown patients die. But I would say America, Egypt, and then in the Arab world, I would contact Egypt, and it's done through the University of Cairo, and it's at the military hospital, and they have many people from different countries that come there. So that's probably the best courses. And then the INS, and I can help you with that if you email me.
Thank you.
Yes, Professor Tawfiq.
Yeah, thank you, Professor Abdelmajid. Just a question for Professor Caldwell and Professor Al-Abadi. So for Professor Caldwell is about first question about proctrinoma situation. The main big problem, the most of this tumor is invasive and not respectful. So Mr. Caldwell, how you manage this patient? This is the first question. And the second question, in invasive cases, do you use ICG to avoid any vascular injury? Operative. Thank you.
Yes. And so can I just ask you, did you mention trauma cases? Is that what you were talking about?
Prolactinoma situation.
Prolactinoma. Okay. Yeah.
Prolactinoma, yeah.
Yeah, sorry. Yes. So in general, we try to treat prolactinomas, especially, you're absolutely right. They're very invasive when they get big. So we try to use medical therapy if we can. So we use cabergoline or bromocriptine as first-line treatment. You've got to be very careful on these giant prolactinomas because they will shrink and then you get CSF leak. And so we'll then go ahead and do an operation transnasally, remove as much tumor as we can, even though we can't get it all out, and then close properly with nasoseptal flap or fat graft to stop the CSF leak. We don't use ICG routinely for pituitaries, but I use it all the time in vascular surgery and in some reconstructions and bypasses all the time. So we would be, if I thought I was close to an artery, I might use an ICG, but we'll use ultrasound like Doppler, usually more often in pituitary tumors than we use ICG. But I would like to hear Lewis, if his thoughts about that as well, if he's using ICG with pituitary tumors.
Thank you. Thank you.
Never had the idea. Maybe, never used. I want to say something about the lab. You know, you have the same situation that you have in Morocco. Our problem is not to get the lab. You have the lab. You don't have the cadaver. The law in the religion, you cannot cut the head, you cannot have the full body. In the preparation of the body is not good. But you know, the problem with the anatomy is, if you go to a course, you learn a lot in 2 days, 3 days, but open your mind. These 2 days, you open your mind. You go there to see Professor Caldwell, do the dissection, do the way he does the peeling. You learn how he does. But you should do at home slowly to learn point by point. You know why you do this? In the anatomy department, in the very old, dirty, and terrible smell cadaver that you have in the anatomy department. You cannot make the picture. There is no injection of the artery and the vein, but you are there to learn. See, if you go, you can do this in every corner in the world. You have anatomy department in the university. I know that's not smell good, not nice, but open your mind, you learn. I spent almost 3 years in the lab in Dr. Omefti, 93 to 96. Don't know which drill I was using. There's no Midas, no Esculap, nothing. It was a Dremel that I bought in the Walmart. See, in this store. I bought the Dremel. But to do a mastoidectomy was 1 day. But was slowly in learning. See?
Yeah.
To learn is not in the way the facilities. To learn is in your mind if you want to do. And you can do in Morocco, you can do everywhere. I'm sure you can do. Go there to do the course, learn with professor, but come back home and train. It's the way to do it.
Thank you, Professor Borba. Maybe Professor Bedi would like to add something. Professor Najia.
Yeah, just about the question that our friend Tawfiq asked us.
Yeah.
Unfortunately,
Yeah.
I don't have ICG, so I can't answer for this question. But I can say that even we don't have ICG, we have to be more precautious about the vessels every time. But in the meningioma, I think it's not the big problem in the meningioma, especially maybe for the lesser wing, the depth location. Yes, it's sometimes it's invaded the carotid artery and some perforators. But if you have it, of course we will use it, but till now not yet. But I have a question, maybe. Thank you. I have a question for Professor Caldwell about 2 questions. The first one is about apoplexy, postoperatively apoplexy. You shown us 2 cases, and I had 2 cases also like this. And I don't. My decision is the make decision after this complication to go to reoperative or just treating medically. It's not easy, and especially when we did surgery by endonasal endoscopic. What do you think about that? And the second question, maybe I will ask my question and you can answer after the 2 questions. It's about the invasion of cavernous sinus, especially in pituitary adenoma. My means it's you go, but you show us very complicated cases, and you go inside the cavernous sinus sometimes, and it's not. We all of us agree for the radiosurgery in this type of tumors. Why you are more aggressive for this? Sure. For which type of pituitary adenoma? It's non-functional, maybe, or but we know that radiosurgery work well for this
Yes.
kind.
So those are excellent questions. Let me answer the first one. So the question is when we operate in the cavernous sinus with pituitary tumors and when we just use radiation. So the patient that I showed you removing the tumor in the cavernous sinus had a 6-nerve palsy and she had already been radiated. So she had already received radiation. So that's why we were more aggressive.
Okay.
But I don't go in the cavernous sinus if the oculomotor nerves are functioning well and it's a benign tumor that's non-functional. I just watch or treat with radiation. But if they recur in the cavernous sinus and the radiation therapist says it's too dangerous to give more radiation, then we will go and reoperate. And we tell the patient that they may have ophthalmoplegia for a period of time. Now, the other reason that we'll go in the cavernous sinus is recurrent functional tumors like acromegaly and Cushing's disease. If they fail radiation and medical therapy, then we will go in the cavernous sinus and try to reduce as much as we can. Okay? So only tumors that have failed radiation in general do we go into the cavernous sinus as a general rule. And then the first question you had was about apoplexy. And it is a difficult judgment because I've treated, like you, I'm sure, I've treated many patients that have apoplexy just conservatively. And you wait a few weeks and they get better. But if the patients lose vision with apoplexy, then we always operate. But if it's just cranial nerve palsy in the cavernous sinus, I think you could probably wait because the nerves, I've seen the nerves get better if we just wait in these cases. And we've had several patients with prolactinomas that have apoplexy, but their vision is okay, but they can't move their eye very well. And we'll treat those with medical therapy, and they often get better on their own because the medical therapy works so quickly. So those are the cases that we treat conservatively. But if people are losing vision or if they're very sick, we always operate. Yeah.
Sure, totally agree. Thank you, Bill.
Professor Azari raised hand.
Yes, I come back. Thank you. I come back for this question of cadaveric training. I know that in education, the cadaveric training is very, very important, especially in vascular surgery. But on this time, the COVID situation, everything is very difficult. 2 days ago, I was in my clinic, some colleagues from ophthalmologists, and the Moroccan Society of Ophthalmology is going to buy one simulator treating the anterior segment and the posterior segment. And I asked him, the seller, if there is something for neurosurgery. He told me, yes, very good machine, weighed 300,000 euro. One machine to simulate every situation in neurosurgery. My question is for William. Did you heard about, there is many machines, but did you have an idea about that in this time with COVID situation? Perhaps it should be a good idea.
Yes, that's a great question. And so good to see you, my friend, Dr. Al-Hazari. I think that for skull base approaches in dissection, cadaver is the best. But for vascular, for anastomosis techniques, we can make simulation. And what we do is we do it very cheaply. So we do course twice a year with our residents and fellows where we get turkey wings or chicken wings and use the artery and it's like STMCA bypass, and we teach bypass techniques that way. So that's something you could do. It's very cheap. They also make little plastic kits that you can sew rubber arteries. and they're available. And I can't remember the company that makes them, but we'll use those as well. And then it teaches the resident how to use the microscope and the instruments. But for skull base, I think it's hard to replace, like for temporal bone or for middle fossa, far lateral, cadaver is very good. And I don't see a simulator replacing those quickly, and too expensive, as you say, too expensive.
Too expensive.
We have simple simulators for ventricular drain, transnasal, but they still don't replace a good cadaver in my mind. But I would like to hear Lewis about that as well.
Thank you.
Thank you, Professor William. Any question or comment from Professor Regonite from Kuala Lumpur?
Hi.
Please.
I think, Bill, Professor Caldwell, I'd like to just ask you, in one of your presentations, you depicted a case that you did with Professor Dio Pujari in Bombay, where the tumor had extended vertically and was rather calcified. Now, on the note of prolactinomas, which are treated with cabergoline, sometimes these tumors actually become rather sclerotic or rather hardened. And I think sometimes we only discover the extent of the hard nature of the tumor during surgery. So, do you have any pointers on how you can actually predict that so that you can plan your surgery or your approach rather than going in transsphenoidally and realizing that this thing is too hard and you have to come up transcranially?
Yes. Yeah, I mean, that's an excellent question. I wish I knew that. I wish I could predict that. We do predict that with T2 signal on meningiomas, but we can't predict it with pituitary tumors. I've been fooled so many times because you get in there sometimes and it's like a rubber ball and you can't get anything to mobilize. And if the tumors are big in those cases, I stop and then I just come in through another approach, and safer approach. So I wish I could tell you something, but I can't predict that. I think for the younger people, one of the risks that you run when the tumor is firm, and I've seen this happen to many people, is that they take the tumor out and they come around the tumor and they end up doing hypophysectomy with the tumor removal, because usually the tumor is soft and the gland is more firm. And if the tumor is too firm, it's harder to separate the gland from the tumor. And I've seen many young people come around it. And I think it's something that I should have mentioned in my talk as well. Be careful doing these extracapsular dissections in a pituitary tumor. Because if you come over, you'll come right down onto the pituitary stalk and the gland, and you'll end up doing hypophysectomy. So always think about that on these extracapsular dissections. I'm not a big fan of extracapsular dissections in pituitary tumor unless I can see it come easily.
Thank you, Professor William. Any other question from the audience, please?
I have
Professor Tof.
Yeah. Right.
Professor Tawfiq, yes.
Yeah, I can. Yeah. Just a question for Professor Abadi. Professor Abadi, about tubercle cellular meningioma. What you do like approaches, and what about the frontal orbital approaches? Thank you.
I do, as I said, unifrontal, of course, subfrontal, lateral frontal for this kind of the tumor. And it's sometimes it's not easy because as I said, we need to, because it's really very deep, and you need to open, it's frontolateral. So you can open the opening, when you open the Sullivan fissure, you can retract the frontal lobe more easily, and you can touch and you can reach the insertion is very important. The insertion of the tumor is very important to start with it if we can, when the size of the tumor allow it. And it's subfrontal and orbitofrontal. It's really it's good a good approach, but in my opinion, suborbital, it's a small approaches. It's for we saw in the literature in many meetings that some neurosurgeon spoke a lot about endoscopic, suborbital endoscopic approaches, but in my opinion, is not easy when you have the big size of tumor. Even most of the endoscopic said yes, but in my opinion, it's not easy to use it.
Thank you.
Thank you. There are two other questions from Professor Lakhdar, our president of Moroccan Society of Neurosurgery, and then Professor Ben Zakmout. Please, Professor Lakhdar. We don't hear you.
I thank all the speakers for their interesting lectures. In fact, my questions have just been answered by Professor Caldwell about the dissection of the tumor from the hypothalamus. We know that for craniopharyngioma, regarding the shape of the tumor and the invasive characteristics, we can't dissect it from the hypothalamus. It's not advisable to do it. But for adenoma, the well-shaped wall of the tumor, perhaps, as you said, it's we try to dissect it from the surrounding structures. When the extension goes towards the hypothalamus, what to do? To leave this part and only to be debulking in this part of the tumor.
Yes, I mean, I would just be very careful if there's a difficult plane between the hypothalamus and the pituitary. I would just do an intercapsular removal and try not to beat up the hypothalamus with that dissection. I'm very respectful of the hypothalamus. One other point that I wanted to make, and I'm sorry, Louis, I had to run down to the OR during some of your talk, but there's a percentage of these craniopharyngiomas that arise within the third ventricle. And it's important to recognize those for two reasons. First of all, you don't want to come in through the nose on those patients because you go through the floor of the third ventricle to get to them. So we'll choose an approach, and I think we've published this, you can come transcortically or go transventricularly to get into them, either transcallosally or transcortically through the foramen to get them, or through the lamina terminalis. And it's important to try and leave the floor of the third intact just for this reason. And the way I recognize an intraventricular meningeoma is I look at the pituitary stalk. And if the pituitary stalk is midline but short, that means that the third ventricle is being pushed down symmetrically. And that is a good indication in my mind that the tumor may be in the third ventricle, and we'll choose an approach so we don't go through the floor of the third ventricle from below. So just something that I've learned. I need to write that up as a technical note.
Thank you, Professor William. Then another question from Professor Ben Zakmout, our Vice President.
Thank you, Majid. First of all, I would like to thank the three speakers for their very interesting presentation. I have a question for Professor Borba. I would like to ask him if he has the same philosophy in treating craniopharyngiomas in adults and pediatric population. I mean, if he go voluntarily for aggressive surgery in adults and less aggressive surgery in adult in pediatric population because of growth concerns, and what is his opinion in infant about staged, what we call staged surgery. Thank you, Professor Borba.
Thank you. I think histologically looks the same, but the surgery in adult is easier than in children. The invasion of the tumor, see, is much less that you have in children. See, because this, in the great majority of the patient, adult, you can get a very nice, not I'm going to say total removing every, but you have a good percentage of recurrence. And the invasion of the hypothalamus is much less. In children is different. In children is different. The involvement of the hypothalamus, you never know how much is totally damaged, invaded, or compressed. And preoperative disturbance is higher than in adults. Disturbance in, see, obesity, this kind of stuff. Good. I believe that in children, you remove as maximum that you can, but always respect the hypothalamus. And adult, you should respect the hypothalamus, but in the great majority of the time, there is one plan that you can remove better than you have in children. And the stage for craniopharyngoma, I don't know if it's a good idea, except if you go for one approach, or for example, you come from the nose, you try to remove to see that it's very stuck, you cannot take it, you can come from the cranial. See, but not preparing stage surgery for craniopharyngoma. See, because the second surgery in craniopharyngoma is very difficult because of the reaction. I say some scar, a lot, some meningitis for the life, for the fluid. See, it's much more difficult. See, craniopharyngoma is first time. See, you never forget. You can never miss the first time. I don't know if I answered to you.
Thank you.
Thank you.
Any other question from the audience? Reda Mazagri would like to. No? Yes.
Good
Yes,
evening,
please.
doctors. Good evening, professors, for the great presentations. I'm Reda Abdelkhataibe from Jordan. I'm a newly specialized or certified in neurosurgery, so I'm a very junior and a young neurosurgeon from Jordan. Professor Nadia, I'm always proud of your talks and your presentations. I met you once in Amman in Marriott Hotel, if you can remember. Yeah.
Yes. Thank you to be with us.
Yeah, my pleasure, Professor. I'm always happy to see you and always happy to see all you professors and Professor Barbara. Actually, I have only two questions for Prof. Abadi, if you can answer me. First, would you usually use any kind of CSF divergence, whether by EVD or lumbar drain during your operations? And my second question is, did you find any preference in histopathology for the meningiomas in the anterior fossa, like most of them would be in the malignant or type 2 or type 3 in the medial sphenoid wing meningiomas, or did you find any difference in histopathology, or it was diverse all over? I hope you can understand my questions.
Yeah. Sure. Thank you first to be with us this afternoon, and it's a great pleasure to see you again. And for the two questions, the first one is about sorry, but I'm really
CSF divergence.
No, never. I will never. I never use the drainage or something before surgery. I maybe in really in a rare case when we have some, I think one or twice time I use it, but it's not in my daily practice. And the second one, according to the location and the histopathology, there is no correlation. It doesn't matter about location, and it's not. There is no specific histopathological type in this location, especially in skull base, not only in anterior, but all the skull base surgery, meningiomas. I hope that I answered to your questions.
I have maybe one or two questions to Professor Naji Al-Abadi. My first question is, does it happen to you to do surgery on twice time, especially when you have brain swelling or bleeding flap? And my second question is, how many time it takes to you to remove all the meningioma, especially the olfactory groove meningioma? And maybe a third question, how do you manage your shape during the surgery if we know that all the problems may occur at the end when they are very tired? Thank you.
Wow, thank you. It's very, very interesting, interesting questions. Of course, it takes time to remove some huge olfactory meningioma, and the learning curve is very important. I think when I start, maybe it takes 7-8 hours. I think now it takes for the last one that I show you no, it's one month that we operated him. It takes 4 hours. It's by opening to the end. The third question is about how to take shape to do sport. It's very important. It's very important, and when you are passionate, you don't think about the time, and you know that the end of operation you be more careful, and always more careful and more vigilant. I always told to my colleagues, you know, I am very tired, but the procedure is now very important. So we need to be to calm down in the operating room, of course, and very, very cautious, because we know we are tired, and in this and the end of the operation, we can some injuries can happen.
Did you happen to you to stop when you have brain swelling? Important brain swelling? Don't know.
Why? I start to doing only unifrontal approach to decompress the tumor, debulking the tumor, and then I come back to remove all the tumor. But when the swelling happen, it's, you know, if you have a good anesthetist, I think it's helped a lot. And you need to open all, of course, when you do skull-based surgery, you need to know to have a good knowledge of the cisterns, and you have to open it. And sometimes when you have a swelling, you have to open also the Steven fissure. It gives you more places, and the brain is little bit more edemacy. Thank you in French. Sorry.
Thank you. Maybe Professor Caldwell would like to add something.
He apologized. He left us because he has doing surgery now. So okay. He sent a message, and we thank him a lot for his participation. And I think it's a time to.
Yes, I think it was a wonderful night. We learned a lot of things. It was very instructive. I would like to thank all the speakers, all the audience, and maybe I will let the last word to Professor Tawfiq from Algiers, and maybe Professor Khadar. Thank you.
Thank you very much.
Professor Khadar, to conclude maybe.
Is he?
Yes,
he's still with us? Yeah.
Yes, again, we thank all the speakers and thank them also for having accepted to be with us in this webinar. Thank you all the panelists and the attendees. and I hope we will meet next week. Thank you.
Thank you.
Thank you.
Okay.
Thank you.
Thank you.
So
Thank you very much.
Thank you to everybody
Thank
to
you.
be with us today.
Thank you.
Participant to discussion,
Thank you.
to the speakers, to the panelists, and we hope that we can see each other personally very soon after this health crisis. So
Thank you.
we
Thank
will
you very
see
much.
you next week.
Thank
Thank
you.
you so much. Thank you again.
Bye bye.
Thank you.
Bye.
Bye-bye. Thank you.
Bye.
Professor
Thank you.
Borba, thank you so much for being late with us.
Thank you.
شو مشكلة؟